All right, so we're talking about oxygen analysis. We want to verify, especially with high flow systems, that the percentage that we think we're delivering is what we're actually delivering. We do it with what is with a calibrated gas analyzer that is specifically designed to measure oxygen, and we do it really every shift or when we make a change in the oxygen percentage to make sure that we're doing what we're supposed to. So it could be the blended or entrained systems, like we talked about, the aerosol nebulizers that are attached to either aerosol masks, tray collars, etc. If you are using an oxygen tent, I don't know what planet you're on, but then yeah, you would need to analyze that also. Anything that has a built-in blender that we would use, both ventilators as well as hoods. The down flow generator and our air to O2 blending system where we're using 2 flow meters. So all the stuff we've talked about before, we can verify that we're getting the correct concentration by using an oxygen analyzer. This is that setup we talked about in the home where we had a compressed air-driven nebulizer, and we're bleeding in oxygen, but how do I know how much oxygen to bleed in? I hook up an oxygen analyzer. And I just turn it up to see the percentage that I wanted, similar to what we did on the OptiFlow, where we adjusted the oxygen bleed-in to how much percentage we were desiring. So what do we need to know about this process? We're going to talk about the different types. We'll talk about how we get to the calibration process, how often we analyze, do maintenance on them, and some other gas analyzers. There's multiple different types of oxygen analyzers. Some of them, like the paramagnetic and the thermal conductivity, we don't see clinically in use. When I started, they were actually there, but they were such delicate instruments that they ended up being more costly to repair. Something like our zirconium oxide, a chemical analyzer, is one that we would see on a metabolic cart, but it's not something that we're going to see routinely in practice as far as in the ICU. The 2 that we will see are the galvanic fuel cell and the polarographic analyzer. So let's talk about the fuel cell first. This is the one that we have actually on the OptiFlow that you can end up seeing. It has a sensor that we place into the environment we were interested in analyzing. That sensor is connected to the box. It's got some really important knobs like on-off, a calibrate button, and basically we're just reading what the percentage of the oxygen is that is in that environment. Just another example of one that is there, and you can see here this T adapter is how it would be placed in line. So say I had that blue large bore tubing and I wanted to analyze what this system was operating, I could put a T adapter in line and put my oxygen sensor right in there, so I can analyze what percentage of oxygen is being delivered. Just another example of another brand, a bit older brand, and another one. And there's that placement of that sensor inside the T adapter so that I can measure what the environment is. What you basically have on the inside is an anode and a cathode. So we're measuring an electrical reaction that is happening. So oxygen diffuses across this membrane, moves into an electrolyte solution. There's an oxidation reduction. Oh God, not that again. Yes, that again. It's operating just like a Clark electrode. That there's an oxidation reduction where oxygen is reduced or consumed at the cathode. It produces a change in the potential at the cathode. So the anode is the reference electrode, and basically we're looking for current being generated because of the reduction of oxygen, just like a Clark electrode we use in the blood gas analyzer. That current can be measured. The nice part about this is there's no battery that is needed. It's an electrical reaction that happens just because oxygen is consumed. And it actually measures the partial pressure, but displays it as a fractional concentration. So it assumes that the barometric pressure is whatever it is, and is that partial pressure then is converted into a fractional concentration. There are some accuracy issues. First of all, water on the sensor. It has to be free so that it doesn't have water accumulating on the tip of the sensor. That's why when we put it in this fashion rather than the other way with the sensor pointing upwards. That way no water could collect on there on the tip of that because it's upright. Oh, that wasn't what I wanted. Second thing, high pressures. Excessive levels of positive pressure will affect the readings also. The one big one we want to keep in mind is changes in altitude. Because it's measuring partial pressure, as you use it in flight, it's going to be less accurate. It's going to have some effect on it. The other thing about it is it's continually operating so long as it's exposed to a gas. So if I just had that sensor sitting out, even though it's not turned on, this sensor is still consuming oxygen. So we have to cap it, okay? Because there's oxygen in the room that's going to interact with that in an oxidation reduction reaction. And I don't care that you know the hours of exposure, all that kind of stuff. But basically, the more oxygen you have in the environment that you're analyzing, the shorter the life of the analyzer. Duh. So if we can't calibrate it, we need to change the fuel cell. You just basically these are designed to be disposable. So I have a little connection. I take it, throw it away, put a new one on, and just screw a new one in. It's a very easy process from a maintenance standpoint. Either it works or it doesn't work. When it doesn't work, we throw it away. If it's not providing the proper FiO2, then I would try to calibrate first. And if it didn't work, then I could go ahead and get a new fuel cell, and maybe something wrong with the delivery system itself. Here's the method by which I would calibrate it. I have a flow of oxygen running into the bag, and what I'm wanting to see is that it goes from 21% in room air to 100% when it's exposed in that process. I know it's a very sophisticated, these bags are hard to, oh no, they're not. So I'm exposing it to 100%, and then I'm exposing it to room air. So a 2-point calibration. We'll skip that lab part. And again, this is just looking at some of the maintenance on it. Again, they're just removing some screws to get at the fuel cell, and the fuel cell gets tossed. You saw in that one, it was even easier yet. Yep. Why do you do this 2-point calibration? You always want to calibrate an instrument that you're using to measure the oxygen environment. So I'm going to measure that oxygen environment at two extremes. 21% and 100%. Probably what we're using to deliver to the patient is somewhere between those 2 points. 50%, 60%, whatever. I guess it really doesn't make a whole lot of sense to, if I have a patient on room air, to analyze that, but. Okay, the second type, the polarographic oxygen analyzer, is a little bit different. It kind of looks the same, has the same kind of a sensor that is attached to this place into the environment. Again, using a T-piece if we're having it in line. And this one, again, has that silver anode and the platinum cathode, same idea, but the difference is there's a battery. So this is an analogous to the Clark electrode that we talked about. It operates similar to a galvanic fuel cell, except that there is a battery used to polarize the electrodes, so there's some electrical current initially put into the system. Oxygen passes across the semipermeable membrane into an electrolyte solution, So here we have a solution that these electrodes are sitting in. It's then reduced, producing a flow, same idea, and again it's measuring partial pressure. It's not measuring truly the fractional concentration, but it's inferred from the partial pressure. So two big differences between a galvanic cell and a polarographic. One is a battery, and the second one is some electrolyte solution. Other than that, they're really similar. It again, because I'm measuring partial pressures, affected by the presence of water on the sensor, high pressures, and altitude. Same exact process. Now the difference here is that when we turn off the analyzer, we turn off that battery, we end up not having that process where the oxygen is slowly deteriorating the sensor itself. Troubleshooting it, if I can't calibrate, first thing to do is change the battery. That makes sense. That's kind of like the question, do you have it plugged in? Check and replace the electrolyte solution. Check and replace the membrane. And you can even polish the electrodes. So there's multiple steps that you can do if you can't calibrate. And if it's not properly measuring the FiO2, again, first of all, calibrate and recheck. And if not, make sure that if it's properly calibrated but it's still not measuring the proper FiO2, maybe there's something wrong with the delivery system. Maybe I have it set up wrong. Here's kind of a little more in-depth view of what the sensor looks like. We talked about this membrane that the oxygen has to dissolve, move across. There's a cap then with inside there is some liquid, some electrolyte solution. They call it gel here. Then I have the stem of the electrode itself that screws into this portion here. So I can take it apart, remembering it, refill it with electrolyte solution, and go ahead and utilize it. You want to keep it again in an upright position in that fashion, same as we did previously. And there we can see we're analyzing our high flow jet nebulizer to see if we're delivering the proper FiO2. Throwing it inside a tent, well, look at that, I just lay it down next to the patient. Or the same thing would be used if we had a hood. So those environments are ones that we can end up using. Most mechanical ventilators manufactured today have built-in analyzers. So we don't even have to calibrate anything. It does it automatically. Now, oxygen's not the only gas that we analyze, as we'll find. We talked about carbon dioxide, right? Capnography is a common thing that is utilized. We analyze carbon monoxide. We talked about that. We did a demo on that with a carbon monoxide analyzer. We know that there's got to be a helium for helium dilution and nitrogen for nitrogen washout. Do I care that you know that it's a thermal conductivity and a Geisler tube ionizer? Nah. Just recognize that there's got to be an analyzer out there for them. One cool thing is something called mass spectrometry, where they basically ionize gas that is being passed, that we're trying to analyze, and as they ionize it, they identify different molecular masses, and from that then they can tell what concentration is there. So they know how much oxygen is there versus nitrogen by seeing the mass of each of the constituent components. Cool technology. Same as gas chromatography. Again, recognize there's other ways to measure gases. That's the big part I wanted to say. Don't worry about it. Okay. Just recognize that there's other ways. So I'm going to take you back to square one for a few minutes. We know there's different causes of hypoxemia. One of the things that you need to begin to integrate into your whole process is if my patient has a low PaO2, why? There's only 5 causes, right? It's got to be one of those 5. And the treatment for each of them is going to be different. Okay? That hypoxemia leads to hypoxia, and again, there's only 4 types of hypoxia. hypoxemic hypoxia, where the PaO2 is low. The other three, the PaO2 can be normal or high. Anemic from lack of hemoglobin or lack of functional hemoglobin, like you would see in carboxyhemoglobin and methemoglobinemia. Circulatory hypoxia from a reduction in cardiac output. Histotoxic, because the cell's mitochondria can't function with that oxygen. Is this kind of ringing a bell? Yeah, guess what? It don't go away. When I used to go out to the clinical sites, when I was the clinical coordinator, I would go up to the therapist taking care of the ventilator. My first question was, why is your patient on the ventilator? Oh, they went into respiratory failure. No shit, really? I thought we just needed some extra money, so we intubated random people and put them on a ventilator. Of course they're respiratory failure! Why? Compliance resistance, right? It's the only, or neurological. It's only 3 reasons of why. Okay. What's your last blood gas? Give me the blood gas. Patient's hypoxemic. Why are they hypoxemic? I don't know. Well, there's only a few reasons. Which one of the 5 is it? Or is that a combination of them in the process? Chances are increased altitude is not going to be the problem. Your patient is hypoxemic, okay? I'm just going to go on a limb and say we're not ventilating. Well, maybe in Dubai that would be. I don't know. Got to find that one out. Any rate. So the indications for oxygen therapy are obviously documented hypoxemia. Somebody's got a PO2 less than 60 for sure on room air, especially if there's COPD. Saturations that are low, either arterial or through pulse oximetry. We talked a little bit about patients with COPD. We're going to be a little more lenient as far as the level of hypoxemia. With neonates, we're also going to be a little more careful in administration because we worry about the retinopathy of prematurity. In an emergency situation, you can usually place a patient on oxygen even without an order. It's kind of commonplace. Just I see a patient come in who's an auto trauma, put them on some oxygen. It's not going to harm for the short term. We used to do routine use of oxygen with acute myocardial infarction. The Heart Association has decided that that might not be the best idea, so that's kind of been minimized, but certainly in the recovery room is another example of where we may do it. 3 primary goals, though. Correct hypoxemia. So if I got an existing hypoxemia, they may need oxygen. And how do we know there's hypoxemia? Hello, we look at the PaO2. Real tough. Decrease symptoms of hypoxemia. So if they're seeing increased work of breathing or increased work of the heart, then I would know I would need to manage that. You don't need to know these numbers. Just basically, this was a study that was done looking at patients in pulmonary rehab. And they found that even in that environment, even those patients that we're monitoring the closest, we still have some gaps that are there as far as patients' needs and are they actually being done. And again, this is something that, unfortunately, the majority of patients in the home, the person they become the most familiar with is the truck driver who brings them to the cylinders. And unfortunately, it's not a respiratory therapist who probably doesn't fully understand what's going on. I think Lori talked about the NOT study. It wasn't actually it wasn't national oxygen. I believe it was nocturnal oxygen therapy trial. But basically, better life expectancy if I wear oxygen. Oh God, not this. We talked about uptake. We know about PaO2. If we don't know how to classify hypoxemia, I think Lori just dinged you a lot on the last test she had. So, and hyperoxemia we know is over 100. There is some degradation that we all have as we age. So we start seeing, because we're losing functional lung, we're also then don't have the amount of surface area involved, and I believe there was this guy named Fick who had this law that said you reduce surface area, you're going to reduce amount that diffuses across. So, and Newborn, I don't expect you to know normals. I'll let Lori handle that when she talks about neonatal stuff. We also know that there's different ways we can evaluate. If I told you the patient's PO2 was 90, your first question should be, well, what FiO2? Because if it's 90 on room air, okay, fine. If it's 90 on 80% oxygen, whoa, time out. It ain't good. How would I know that? I could do any of these measurements. I could look at that PF ratio. And what we can also look at, especially in patients that are cardiovascularly compromised, is looking at the lactic acid. I'm going to say a bad word. Krebs cycle. Oh, oxidative phosphorylation. Yeah, baby. If you don't have oxygen, you got to go through that alternate pathway and you end up creating lactate. So we can measure the lactic acid level to see to what degree we end up having problems with the anaerobic metabolism. Novel idea, if their oxygen is low, we use oxygen therapy. Whew. Scary. But remember, in certain causes of hypoxemia, i.e. shunt, you end up having a situation where it becomes refractory to oxygen therapy. You need to look at something else. That's where we're going to get into using PEEP and CPAP, as we'll find. We'll do things like improving their tidal volume by having them take deeper breaths in to improve ventilation and reduce the amount of atalactatic areas you end up having. We'll do things like doing bronchial hygiene to clear secretions out of the way that may be blocking the airways. And we talked about bronchodilation. I know you know all about some pathmimetic adrenergic agents. Efficiency of caring, again, looking at not only the hemoglobin. This should all be a beer review, right, guys? Okay, good.
I got a quick question. Sounds slow down, right? But some spots offering oxygen therapy, but you can go there for refreshment, replenishment.
Sure they are. They're not.
They're not.
They're not. It's not oxygen.
Oh, what is it?
Air.
Oh, it's air.
Oxygen is
So I said, like, why
is there a physician there prescribing this? They call them oxygen bar, flavored oxygen. Yeah, no, it's air, and they're putting some lavender in there. It's a farce. Don't buy it. P50, remember? The partial pressure at 50% saturation, normal value 27, tells me the shift of the curve, left or right. Oxygen content, oh yeah, that doesn't go away either. And how we treat for a low oxygen carrying capacity, transfusion, but really we don't transfuse unless the hemoglobin gets below 7. So it's a pretty profound anemia you have to have before they'll do something about it. And abnormal hemoglobins, obviously, we can treat pretty aggressively. Oh no, it just doesn't go away. The second years right now are sitting in a test on hemodynamics, so it comes back over and over. Oh, pulmonary vascular resistance, please no, shunt fraction. And we know there's various ways we can treat those deficits. So if we have a problem with preload, either too much or too little, what do we do? If we have a problem with contractility, what do we do? And then looking at the utilization by the tissues, we typically look at the mixed venous partial pressure. That's why the V has a little line over it. But we can also look at some other stuff. And we talked about extraction. If the problem is that the utilization, the problem is not the delivery, but the problem is the fact that their oxygen consumption has gone up, we need to figure out how we can fix that also. Okay. I want you to know that there is this thing called lactic acid that we can measure. I don't care you know the normal values because there's actually two ways to express it. This is in millimoles per liter. The other one I believe is, I'd have to go back and look. But there's two different ways that labs report it. so I'm not going to worry about a normal value. But obviously, you have the combination of hypoxemia along with reduced cardiac output. So the last bullet point is the important one. If I have a poorly perfused patient who's hypoxemic, ooh, there's a little bit of alliteration, chances are they're going to be hypoxic and developing lactic acid. How do I know there's inadequate oxygenation? The biggest one to look for is tachycardia. Body's first response to hypoxemia is to speed up the heart rate and speed up the respiratory rate. We also see all those other signs and symptoms those clinical manifestations, things like mentation change, things like lack of coordination or visual disturbances where the vision becomes blurred. So what do? We do some measurements. We do things like arterial blood gases. We do things like CO oximetry to make sure there's not an elevated carboxy or met. We can measure the lactic acid. We can measure things non-invasively, like through pulse oximetry, be it during ambulation, during exercise, during sleep. We talked about transcutaneous, and I think I might have mentioned conjunctival, where they were put a little sensor into the conjunctiva of the eye. That is just wrong. I can wear a sensor on my fingers. Oxygen is a drug, so it requires a prescription, either directly an order from the physician or protocol that's been established that if the patient meets certain criteria. It's our role to make sure that the need is there. It's a drug, and it is a drug which will kill you if you give too much of it. So maybe it's needed not while they're at rest, but only when they're ambulating. And what device is best for the administration of that? Will a nasal cannula do, or do I need to look at something like an air entrainment mask? Oh my God. This is out of vegan. It's right there. It makes it scary, right? But basically, there's step-by-step fashions that we have to administer this. Some of the precautions, remember, certain instances, like a large shunt, oxygen's not going to help you. You're fooling yourself. You need to get those alveoli re-expanded. Has Lori talked about, or have you heard the term hypoxic drive? I think we talked about it a little bit in here, but just as a reiteration for those that might not have heard it. Normally, you and I breathe because our carbon dioxide levels transiently rise. Stimulates the floor of the fourth ventricle in the brain, the medulla oblongata, blah, and we take a breath in. If that you have chronic hypercapnia, that mechanism doesn't work really well. So they breathe on a different mechanism where hypoxemia becomes more of a driver than anything else. Bottom line is patients that have carbon dioxide, chronic hypercapnia, COPD patients, the provision of oxygen to them has to be done judiciously because you can have what is called oxygen-induced hypoventilation. Why it happens, it's a longer story than just we knocked out their hypoxic drive. There's more to it than that. Okay? But COPD patients, you got to be careful, especially with low-flow devices. What happens to the FiO2 as minute ventilation falls? It increases, which is only going to make the matters worse. Okay, so you get this cyclical process. Oxygen, high concentrations of oxygen can actually wash out the nitrogen. So you end up having all the oxygen being consumed, and so we wash out the nitrogen out of the alveolus. All that is in it is oxygen. That oxygen then diffuses into the bloodstream, and the alveolus collapses because there's no nitrogen to hold it open. We call that absorption atelectasis. Oxygen toxicity, again, it can be harmful. It can create what's the word I want to use? Oxygen-free radicals, which can cause damage to the tissue. They can have high levels of oxygen can affect the cilia in the airway. We talked about retinopathy of prematurity in premature infants. It can cause blindness. You can cause the patent ductus arteriosus to close. Well, Rick, I thought that was the whole idea. Oh no, my friend. There are times where we want to keep the ductus arteriosus open. For certain cardiac defects where if you don't have that ductus arteriosus open, you die. So we actually administer 17% oxygen to these patients, lower than room air, to purposely keep it open. Worsening of lung injury, some poisonings like paraquat poisoning or patients on bleomycin, oxygen can actually cause harm. This is a good one. An ignition hazard during laser procedures. So the surgeon is doing some lasering in a high oxygen environment that could start a fire. A fire in your patient, I'm just going to go out on a limb, is not going to be a good outcome. Okay? So it needs to be treated with care. I mean, it's not just something we use wildly. Some of the symptoms of oxygen toxicity, I'm not going to ask you specifically on them, but just recognize that high levels of oxygen do cause problems. Leave it at that. And it's the big problem that goes on. If you have oxygen toxicity, you destroy the lung tissue. The lung tissue collapses. I have increased shunting. Increased shunting causes low PO2, which means I'm going to put more oxygen up and it keep going in a circle that doesn't get anywhere. What we really need to do is, if I'm seeing shunting, stop with the going up on the oxygen. That's not going to fix the problem. So usually when you get an assignment as a clinician, the next Monday or Wednesday when you're working with your folks in the ICU, they typically are just in the ICU, but they may have some clinical assignments outside the unit. They may have the unit next to the ICU just to monitor the oxygen therapy on patients out there. So we want to verify who's on oxygen, make sure the orders are there, and then going in and assessing the patient. We look from the patient back, so again, that's why we always do that scene survey, primary survey. Are they breathing? Do they look good? Do they have good color? We then go ahead and take a look at the oxygen itself. Is the system working correctly? If they're on a humidifier, we may test the humidifier to make sure we hear that pop off. And if something is low water level, replacing that, or if the nasal cannula is lying on the floor, disgusting, getting them a new one. We also check the emergency equipment that's on the crash cart. Every crash cart that I've ever seen has either a drawer or a box for respiratory means, which inside the box is a resuscitation bag, some mechanisms to maintain an airway, maybe blood gas kits, just anything possible that we would use as respiratory therapists. There's also usually a cubby or some closet that is designated for respiratory equipment, which is on the floor. We want to make sure that all the stuff is there. We know about low flow equipment. We want to verify if they're using a humidifier, that the water level is appropriate and the pop-off is working. And we typically clean those once a week if they're not already discharged. By that point in time, most patients are out of the hospital. Anything wet, we're going to change daily. I think I mentioned that before. Make sure the drain bag is at the lowest point in the circuit, and then we can drain it. And again, if the patient is on greater than 50%, is the flow of the patient enough to match can the device meet or exceed the patient's needs? Maybe they need a separate setup for eating. Does the patient need longer tubing to sit in a chair or go to the bathroom? If they are ambulating, well, let's accommodate them. Does the patient need a cylinder for ambulation? And what about if I find a patient, where did you come from? I see oxygen on your face and I don't even know who you are. Well, he might have got transferred from another area and we were never notified. So we want to make sure that we got that. Or conversely, if the patient's being transferred to another unit, we may have to have a situation where we accompany them for that transport, although a lot of hospitals, the transporters are trained on how to end up using oxygen. Home oxygen therapy, just want to make mention of, there's specific things that need to go on us. The device, the concentration or flow that they're going to be utilized, and how often the patient's supposed to use it. Durable medical equipment, or DME providers, are the people who will end up providing the equipment to the patient. Medicare only will reimburse that DME for 2 years. I believe that's still the case. After that, it's the patient's responsibility to be able to maintain the equipment. And you're talking, I think 300 or 400 is pretty conservative. I think it's probably higher than that nowadays. What kind of patients use oxygen at home? Patients that may need it during night. Devices. And again, does the patient qualify? There's 3 different situations that Medicare has said, and believe me, if Medicare comes out with a guideline, pretty much all the insurances follow those same guidelines. So they're kind of the first person. Group 1 says anyone who has a PaO2 less than 55 or an oxygen saturation measured with CO oximetry less than 88 at rest. Okay, and this is not something where, this is prior to discharge. This isn't something where you find the worst blood gas that they ever had and use that as your index. Okay. A PaO2 less than 55 or a saturation by CO oximetry less than 88 during exercise for a patient that has a PaO2 or a saturation higher than those other first ones. So if I can document that they desaturate during exercise, they can qualify. In that case, supplemental oxygen is provided for during exercise use only. If we can document that the oxygen level improves. So less than 55 or an arterial saturation less than 88, or if that isn't met, does that happen during exercise? Second group, well, what about if they're in that range of 56 to 59, or their saturation is at 89? We can justify oxygen if they have some of these other diseases, like CHF, like pulmonary hypertension or cor pulmonale, like somebody who has polycythemia, which is indicative of the fact that they have had chronic hypoxemia and the erythropoietin is kicked in to create more hemoglobin. Okay? So 55 is the magic number. We can take 56 to 59 if they have some other pathology. We can also justify it at night if they have those values of 55 or 88% during sleep, even if they don't qualify while they're awake. And the last bullet point just kind of reiterates what it said previously. Some of the diseases that are more common to utilize oxygen at home, things like COPD, things like interstitial lung diseases, things like cystic fibrosis and bronchiectasis. She's starting in cystic fibrosis today?
No,
Bronchiectasis, okay. That's a disgusting one. It's just, yeah. You'll find out why. And patients with lung cancer can end up qualifying also. Just some other diagnoses we talked about. Again, hypoxia-related symptoms or conditions that can be documented to support the use of oxygen. Lots of protocols that are out there. One of the things that you as a respiratory therapist may be involved with is you get a notice from either the discharge planner or from the nurse on the floor that this patient's going to be going home tomorrow. They're going to be needing oxygen at home. Sometimes discharge planning handles this. Sometimes the respiratory therapy department handles this, where they'll basically contact the home care company and say, this patient's going home, and here's their demographic information, here's their insurance information, et cetera, et cetera. So this is just basically a protocol that walks the therapist through each step. This is the form from the Centers for Medicaid and Medicare Services, the CMS, and this is called the Certificate of Medical Necessity. This is basically the form the physician has to fill out to justify that that patient needs home oxygen. So, and like I said, because Medicare and Medicaid do it, pretty much they all do. So we want to also take a look at, as far as the home, do they have enough electrical outlets? Do they have, are they grounded outlets? If they don't have a backup generator, we'll need to notify the electrical company. We need to actually do it either way. If they're using cylinders, either gas or liquid, there needs to be a safe spot. We talked about proper securing of cylinders specifically, and we'll also notify the fire department also. And then there's some places, this is out of McLaren Macomb, I don't know if they still do this or not, but I wouldn't be surprised if they did, where they basically give some patients some patient education tools as far as stuff that they should know about being at home. Are there precautions and any other things I should take in using oxygen? Yeah, how about not smoking? And then once they get home, usually there's a call that is made to them, asking them how this process is going, is the equipment working okay. If the patient begins to, or seems to be unstable, they may need to have some other intervention like a blood gas to see if there's any clinical change that needs to be reported to the physician. And for those long-term patients, we may need a blood gas and oximetry to follow the course of the disease, although it's usually there's not a requirement necessarily for recertification. Travel, again, just common sense things that the patient should be aware of. Stopping for rests. Travel by car. We talked, I think, a little bit about this. Make sure the cylinder doesn't roll. Travel by bus. Go to Greyhound or train. By a cruise line. There you go. Wouldn't you like to have that job? Be a respiratory therapist on a cruise line, working for COPD cruises? Now I'm talking, you know? And travel by airplane. We talked about portable oxygen concentrators now are allowed in flight, which is good. Now, you laugh, but that person's a genius. They didn't have a spoon, they wanted soup. All right. So, in the meantime, for the balance, if you want to work on your capillary blood gas process, because that PE is Tuesday. How many people are going on Monday to clinical? And Wednesday?
I think it's everyone in the morning class.
Because you're in the afternoon class. That's why that ended up happening. Again, I'm asking the second years, just so you know. I want them to. I'm telling them that you're going through and learning oxygen therapy, so to reinforce why am I using a non-air breather versus a venti mask versus a nasal cannula, kind of giving you some clinical background with that. I'm also asking them to give you a flow meter and pop it into and out of the wall, just so you can learn how to. It looks like, boy, it's pretty easy, but yeah, the first time you do, go, wow, that was a lot harder than I thought it was going to be. And hopefully you won't fall in the bed with the patient like one of my classmates did, but it's a whole separate issue.
Ray,
What?
please class on Wednesday, the 21st.
If you're going to clinical on Monday, then you'll have class on Wednesday. If you're going on Wednesday, then you'll have class on Monday. One or the, I'm doing the same lecture on both days.
At one point,
What? 1 point?
lecture,
Yeah.
For the flow, you said that there was the self-assessment, putting it all together. But I guess there was another one before that. Was this?
Yeah. There's the putting it all together. asks you to calculate the device flow, the patient's flow, and does it match or meet. Each of those components are separate self-assessments. So there's a whole self-assessment on how to determine device flow. There's a whole self-assessment on how to determine patient.
No, it's not a big deal anymore.
All I want is the third one. And we're doing that by the test date, which I believe is Tuesday the 27th. The sputum bowl is the 28th. What about it? Sputum bowl. Hello, 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 hello. Sputum bowl on the 28th is going to be in the University Center. Okay. There'll be signage there, but it's in Lecture Hall B. You remember where you went for orientation? It's in that building, but it's not in that room. What should you expect? People will be laughing at you. You'll be crying. I'm kidding. Do you know what the sputum bowl is?
No.
Okay. It's fun. It's a blast. It's a blast. So it's basically teams. I don't know, would you say you have 3 or 4 on your team? And you're writing questions so you know what the questions are. You'll have buzzers. Each person will have a buzzer. And whichever team buzzes in first, that team gets to answer. If they don't get it correct, then the other team gets to answer. That's all.
Okay. And it's at the UC Center.
At the University Center.
Okay.
It's fun. You don't look like you're believing me. But Macomb has the students from Macomb have won the state level the last 10 years.
What? No way.
Straight.
That's awesome. That's a lot of pressure on her next year. Oh, that's a lot of pressure.
Do we know what the sputum bowl lights are?
I did not see those when I was packing.
I may have taken them. I'll have to check. They're up at my cottage. Okay. Oh, know that.
The ABC homework we had. I can't remember if I turned it in or not. Cause I can't.
I will check, and if I don't, I'll send it to you.
Okay. I was gonna like rewrite it all out.
Rick, are you checking something right now?
Yes, you did not. So I will send you another one.
Is that the only
Do it right now.
that we have? 'Cause I didn't do it.
There was an EKG one also.
All right.
That's fine. Oh. You completed that, I believe. You did not, though. Correct? You didn't fill out this, did you? Okay. Throughout this packet, you're going to need to sign and date. You don't need to do this, and there's a quiz in there. You can just skip that. But each one of these, you need to sign and date.
Am I buying a house?
You are.
Oh.
It's exactly like buying a house. In fact, buying a house, you probably don't sign your name as many times as you will on this. Let me go back and get yours while I'm thinking about it. Bird needs one. That's right. Bird, I need you to, this is for confidentiality for all the healthcare facilities that we attend. So I need you to sign and date wherever you see a sign and date.
My life over.
You are. You are. You can skip this part here, and there's another part in here where there's a test. You can skip that also.
Okay.
But if wherever you see signature and date, go ahead and sign that. Thank you. You can sit, because there's a lot of signatures. I must have taken the sputum bowl things. I'm just trying to think of where I put them. I wasn't. You'll wait and see. Yeah. How's our pressure this morning?
Actually, you know what? Let me tell you something that's totally different. So the doctor that I worked with, regular MD, right? So my OBGYN gave me what they usually do for preeclampsia, but they're not good in just like doing blood pressure, right?
Management.
Management of blood pressure. So I went to my MD. My MD is retired, so it was like some person up in there, and they told me to take metropolol this way, right? Which I did, which obviously didn't work out for me, obviously.
Right.
177, oh, that's pretty high. So once I got into the hospital, they said, like, who idiot told you to take this pill 3 times a day? In your condition, you just take 2 water pills, start off with 12.5 and see how it goes. And I started yesterday. I feel so much better. I take it in the morning now. And I thought I was going to die. I mean, my heart was
Yeah, you were scaring me.
I mean, my heart was racing so bad. And she's like, okay, stay calm, you know, be cool. But I was not in good condition. I'm telling you this.
Well, I'm glad we got it taken care of, and you're back on the straight and narrow.
Yesterday, you know, I'm just now with my new MD. She's young, she's cool. I said, like, okay, and if it's not going to be enough, then we're just going to go.
Then we'll work from there.
Exactly.
Good. Did you buy that house yet?
Not quite yet. I'm still working on it. Exactly for my credit score on that
I
stuff.
did compensation.
Yeah.
I'm on compensation.
I didn't do all that.
Yeah.
In there?
Yeah.
You're going to go over that today, right?
Gonna go over what?
Oh, the exam.
Nah, blow it off.
I just want to see my ABGs.
Okay, I have a question.
I have an answer.
Okay, so, when you have the low PaO2
Yep.
in emphysema,
Yep.
it's normally the diffusion, deficit, or hypoventilation, right?
Or VQ mismatching.
Again,
Oh, that's probably the most common cause. Yeah.
What do you say?
Cause of hypoxemia and COPD.
So why would it be a V?
Because they have areas that are underperfused, and they have areas that are big dead space. So I mean, it's
But will it
a
make
little bit of both.
difference if you're talking about like panlobular or superlobular, or
No.
both are V?
Nah. Nah. They're both.
Okay, I'm not done.
Oh, okay.
She has a whole lot of questions.
Okay, so chronic bronchitis,
Yep.
that would be VQ mismatch, but that's the only one. Or hypoventilation.
They can be blue bloaters. They can be
But
hypoventilating.
not like the, if there's no diffusion.
There's no diffusion defect. Correct. Yes.
And bronchitis?
And bronchitis.
And then asthma, just hypoventilation.
Or VQ mismatch.
It can be
Yeah.
VQ.
Yeah. Pardon me?
Bronchitis.
What's that?
Does the phlegm cause diffusion problems?
Mm-mm.
Bronchitis.
That's the hallmark of
Oh, yeah.
of an emphysema is a diffusion defect. Yeah. Air bubble. Air bubble. Air bubble. Keep it level. Keep it level. Keep it level. Keep it level.
She's like, you don't even look like you. She's like, your eyes are all crossed. I'm like, oh, I was out in the hallway doing shots. She goes,
Look, my hands.
This one?
Like your face.
It's like, I first didn't understand.
Keep that level.
You gotta understand, she's gullible. So look at this. It's her birthday and she's getting poked.
I know. Whose birthday? Hi.
Oh, happy birthday. Oh, yeah,
Keep it on the graph and it'll draw in.
alright, so now.
It beats getting spanked, right?
I guess, yeah.
Oh, hello. Hello.
You want to keep it, try to keep it below her breast.
Do I have to have you sign this too?
Yeah.
Oh, you guys keep all these records for 6 years?
Isn't that ridiculous?
Wow.
I got a stack for each class.
Oh.
Can't we have one form?
Right? No, it's not.
Freaking lawyers. No, skip that. They're not getting my parents' signature. Oh, they're dead.
Yeah, I'll be your witness. No, I'll be witness.